I'm very grateful for the topic because I'm very passionate about adolescents. They constitute majority of my patient population in Washington, D.C., where I deliver clinical care to almost 300 patients, and also the very, very passionate cohort of people with whom I work globally in Africa as well. So I have no conflicts. So what I will try to do in the time that I have is to cover a hugely enormous topic. I will try to give you some glimpse into the epidemic landscape. I will then address the cascade of prevention, testing, ART, and retention meaning also viral suppression. And I will, for each of these steps of the cascade, present you the challenges that are associated with adolescent populations, and will provide you some examples of the opportunities moving forward, some novel approaches. And then finishing up by some important considerations for research and services for adolescents. So as we start, it is current estimate that there are 1.8 million of adolescents living globally with HIV. As you know, these are all estimates. These are not exact numbers. And it is about 5% of all people living with HIV on the planet. If you look at the distribution by the regions, which is the circular graph in front of you, you see a dark purple being the majority of it. It's 61%. That it's clearly the area that you all are very familiar with. It's sub-Saharan Africa, African region. And then 24 West and Central Africa, so Eastern and Southern Africa is 61 plus 24. So if you do the math, you will have the majority of infection in this part of the world. If you look at the dark green one to follow it on the top, it's South Asia. So again, you know, this is distribution which we are familiar with. And what I want to say about this graph is that it is very important not to lose focus on 5 and 1%. When I start talking about the smaller percentage, I'm always worried, especially after this very depressing first session that we had today about funding, that we are going to lose the focus. And I will try to defend these populations as much as I can in my following slides. When you look at the new infections, and again, adolescents are defined differently by countries. WHO defines them as 10 years to 19 years of age. In the US, for example, we define them starting at 12 years of age, so young people are defined through 24 years of age. So if you look at the definition, if you look at the new cases, they also are broken by age. 15 to 24 years of age is about a little over 500,000, and 42% of those are 15 to 19 years of age, so just a little bit less than a half, and they represent 16% of the new adult infections. But please do look by certain regions, the same that I covered previously on the bar graphs, and you will see that in red we have girls, and it's 15 to 19 years of age, and in blue we have boys. And we can see how different the new adolescent infections are among different regions. If you look at the African regions, which are at the bottom, along with Eastern Europe and Central Asia, you see the predominance of new infections in young females. But if you look and move up to East Asia and Pacific, if you look at Western Europe, etc., you will see that the shift is going on much more toward male, and that's where you see most of the MSM new cases along the young MSM. However, with all the African numbers, absolute numbers, the female dominance in the adolescent infection is still quite strong. And indeed, if you look on the global level, if you step back now from region and look at the global level, of every 5 new HIV infections in the populations 15 to 24 years, 3 are among young women. And I just want to remind ourselves that a lot of these young women are already pregnant, and whether in marriage or outside of the marriage, so it really creates the whole other conundrum of mother-to-child transmission risk and the need for ART and adherence to ART during breastfeeding period and pregnancy, which are very challenging. We won't have time to talk about this, but it's a really important topic. Along with the numbers looking at HIV, we do need to recognize that there are very interesting dynamics in the young populations globally. This is a projections that PEPFAR uses, but they were developed by the World Bank. This is projection of the global populations all the way to 2050. And what you can see there are several lines. One is China, one is India, and one is Sub-Saharan Africa. And you can see that there is some flattening on the new numbers on the lighter gray color. I wish the colors were better. Some kind of flattening of the curve for the India. There's a clear tendency to decrease in young populations in China. But if you look at Sub-Saharan Africa, this line just keeps going up, which tells you that along with the new cases, we have a very big, we call it bulge of the youth populations globally. And as a result of this bulge, this is what is projected to happen with epidemic size. So if you look at the pediatrics, we know we're doing a great job, especially with new drugs, with the mother-to-child transmission, we're preventing it much better. So the size of perinatal pool of 0 to 14 years is shrinking very nicely, and the red circles becoming smaller and smaller toward 2020. Look at the right, far right. Yours is far left. Yellow circles is 25 years and above, and it is shrinking as well, but maybe not as much as we wish. But look in the middle, these are 15 to 24 years of age. So this is a combination of the ongoing transmission plus the bulge of the youth population that I've just showed you. And we are not seeing a significant decrease in the circle as we wish for. So what are the challenges? And again, I'm going along the cascade right now, and there are many, and I will not even cover all of them. So some of you in the audience who work with young people might think of some more, so I apologize if I didn't cover them all. But these are the major challenges in the prevention area. We still have a lot of countries in the world that require parental consent to access any kind of sexual reproductive health services, including identification and prevention of HIV in the world. There are very few countries that don't have a majority of this, by the way, age of consent is 16 to 18 years. There are only a few examples that allow the age to go down. This, for example, in Africa recently, Lesotho lowered the age to 12 years. In the US, we use age of 12 years in the Western Europe, but all over the world, it's still majority 16 to 18 years. 26 out of 100 countries that have a national preventive strategy for condom distribution nationally, only 26 of those have included distribution or promotion of condoms in the secondary schools. 67 countries continue to criminalize same-sex sexual relationship, and it's particularly relevant to the countries where you've seen the bars being fairly equal between females and males. And 1/3 of adolescents globally have very more or less comprehensive knowledge of HIV. 2/3 have really no knowledge, and there are multiple data to support it globally through different questionnaires. Our youth is not educated about the risk of HIV. And finally, if you start thinking about PrEP, and we have some fantastic drugs now to do that, there are very few programs that have integrated PrEP, SRH, sexual reproductive health, usually require risk factor screening. We recently had a panel with young women prior to CROI, and they were talking about from Uganda, Zambia, and Kenya, and they were saying that they know people who wanted to go on PrEP, and when they come and they're being screened for risk, they are told that they don't have enough risk factors to go on PrEP. Now, in my opinion, if a young person asks for PrEP, he should or she should be just given that PrEP. There should be no further discussion. But this is what's happening on the continent. And adherence to PrEP is challenging. As I will discuss, adherence to ART is challenging, so we really need to have some solutions. So this is a very global spectrum of challenges. Let me give you some examples of the solutions. I don't have them all. You just heard about self-testing in the panel earlier today. It's still really not a moving target. We know we have the test. We know people can do that. But just to say that there's still a lot of barriers. So first of all, and one of the biggest barriers, I just want you to recognize, I don't have slide data to show you, but believe me, because I just didn't want to overwhelm you with slides, that adolescents now on the regions of Africa carry the most burden of communicable and non-communicable diseases. So a whole issue of adolescent health has been really neglected for years, and it needs to become in the focus, and special focus needs to be placed on girls and women. Tremendous mortality from childbirth still is going on, and other health conditions. Mental health has really not been addressed globally in adolescents. Just to say that we shouldn't look at HIV just through the narrow spectrum. We also need to achieve the lowering of the age of consent. Sexuality is an individual's right, and it is his ownership. The parents, the guardians do not own the sexuality of an individual. So individual has to have the right to access anything related to the health and sexuality without somebody who has given them birth and fed them and even takes care of them still financially and logistically, because their own sexuality is their own life. Wider access to HIV prevention within SRH and general health services. We need integrated health programs. We need to have an adolescent who has come for headache somewhere or the broken arm after fighting with a friend at school. Somebody needs to be around who can gently and very delicately and a very inappropriate, age-appropriate manner slip in the message for sexual reproductive health. Making SRH use-friendly, being not judgmental, not asking how come you're 14 and you're asking for PrEP, you shouldn't be having sex, and just talking about safe behaviors. Increasing knowledge about HIV, SRH, and safe behavior among youth, and we really have not some really great studies. We really have not scaled up yet the use of digital tools. There are some interesting developments now in gaming, where you can teach through gaming some negotiation skills about safe behavior among youth. Social media is quite underutilized. They can gossip about what Justin Bieber is wearing on the last concert, but instead there could be a really good topic of being safer and having more fun with sex. Educational sector and community outreach are still really not used. Schools are very restricted. I go to sex classes in Washington, D.C., and I can tell you every time I come out, I feel very discouraged, because I still think we don't talk right way about sex with our youth. Increasing adherence to PrEP. You just heard a brilliant talk on the long-term injectables, implantables, ARVs. Will the young people take them well? We still don't know, but that's a good option for them. Many of them will say they really want it. And combined with contraception for girls and women, as I have shown you, very high rates of very early pregnancy. And just to give you some hope light, I wanted to show some recent report from UNAIDS. This is percentage reduction in new HIV infections from 2010 to 16, and we're making some progress. It's not maybe as high as we would like it to have, 15 to 19 years, but please look at the bottom. I'm very proud to show you Thailand has decreased by 51%, and in big part because they really took quite a bit of barriers. And if you look along this region, Myanmar, 28%, and really India, 20%. So again, you know, we are not still there yet, but there have been some good strides in reducing new infections. Well, how about testing and identification? Again, the age of consent is a big barrier. 45 countries have laws that impose the need for parental consent to test a young person younger than 18 years of age for HIV. Plus, 50 countries have the same laws specifically defining 14 and less than 16 years of age. 23% of girls and 17% of boys in Africa, Eastern and Southern Africa, most heavily affected by epidemic, have been tested for HIV in the last 12 months and actually received test results. So we really know that the majority of the youth still don't even know their status. And if you look at West and Central Africa and South Asia, these testing rates are even lower. This is just shows you some, it's a bit older data, and you know, I like to always bring the latest data, do the latest searches. I couldn't find any single data point from UNAIDS or UNICEF or anywhere else with WHO where there was a summary of testing ongoing and results received in the use in the recent 5 years. So I apologize for showing you a bit older data, just because there is no comprehensive summary published yet. I hope at Mexico we'll see something. But on the left you see female, on the left, yeah, you see females, on the right you see males, and you can see in the gray bars, these are the 15 to 19 years old, and look at the bottom percentages. Quite majority of them are less than 50%, particularly for the younger cohort. This is usually the onset of sexual life. And with the numbers of pregnancy I've shown you, it's actually really shown we're under-testing them. What are the opportunities for identification? Decreasing age for independent consent would be, for me, number one. Integrating HIV testing into health services for adolescents. HIV testing shouldn't be special tent where you just go for HIV testing. HIV testing should be offered everywhere. It really took me a while, but in my emergency departments in Washington, D.C., I'm proud to say it doesn't matter with what you came in. If you are 13 years and above, the electronic medical system generates the request for the test. You can decline it, the young person can decline it, but it automatically reminds healthcare provider to do the screening. Efficient testing strategies. How how to find them. You heard this first session again, to me it was depressing because we face a crisis with funding and we really need to address it. But as the numbers go down, there is more pressure to identify. And when we start showing our prevalence rates, if there are not that huge numbers, above 10% or 5%, usually the funders even will tell you this is not enough. Find them. How to find them? Index case testing, partner testing, repeat testing within PMTCT cascade. We test women right now usually in the first trimester, but young women continue to have sex and older women continue to have sex while they are pregnant. And usually we miss quite a bit of infection, not only through pregnancy, late seroconverters, but particularly in the breastfeeding as well. An innovative approach for HIV testing. HIV self-testing is still really undertaken in youth population. The recent paper by Hadzel showed the STAR project, the highest proportion of first testers were in 16 to 24 years of age. So we know there is interest and uptake is great, but we really have not done much to scale up self-testing. And on the right, I show you latest publication by WHO. It is about consolidated guideline for self-care interventions for health. If the women can self-inject contraceptives, why can't we consider more self-management in young populations, just teach them how to do it right and support them? And showing you some success with identification as a case finding. This is a study from Lesotho, and what they have done, they simply tested adolescents as index case finding from any adult who was identified positive in the household and the partners, sexual partners of the people who were just newly diagnosed with HIV. And look, the cohort would look at the prevalence, the incidence rates, how high they were, 17% and 20 plus years old, 5.6% in all other channels, and in the blue bars, 2.4% in 15 to 19 years old when you did it through index test, in this case testing, versus some other journal venue. Again, still underutilized way to reach young people. So how about challenges with antiretroviral therapy? Adherence, and many of you know, is a major barrier to the success of ART in young people. Recent study published by Cracker, published very interesting by self-report, the adherence is 87 to 92%. The same young people using the Wise pill box that electronically talks to the device and reports the actual number of openings of the box. We don't even know if the med was swallowed, pills were swallowed, but the box was open in the same population that self-reported 87 to 92% use, 35-64%. Adherence on DTG less than 90% in impact study. It's a small study, very small numbers, but this is 12 to 17 years old, and they've really seen significant virologic failure in only those who have been adherent less than 90%. So it's still, even with the good and forgiven drugs, there are some signals in the use that, and it was self-reported adherence, that there is, and if you count 90% on the previous study, the actual adherence probably was quite lower. It's still a big challenge. Toxicity issues, long-term toxicity, in particular for females and young girls, and I covered it in the previous workshop, or issues with DTG and contraception access, and poorly developed pharmacovigilance system. We really still don't know the toxicity. And one issue I want to just highlight is a big topic for us right now is drug-drug interaction with TB meds and contraceptives among youth in particular. So just to show you, again, to highlight the challenges, in addition, is access to treatment is still quite limited. This is the data from UNAIDS and UNICEF combined data, but these are the distribution by different regions of the access to ART among 10 to 19 years old. And you see that the percentage jumps anywhere from almost 5% to 2% to higher countries. But if you look at the dots, the majority are still under 60%. So what are the opportunities? Fixed dose combinations. Pedro very elegantly, Dr. Khan said this morning, oral long-term is still the preferable. Nobody wants needles of any kind. So if you could swallow a pill that lasts 6 months, that would be ideal. It's probably a dream. Simplification strategy, short cycle therapy. I will show you now results right after breather study in adolescents. Dual ART is quite understudied. We still don't know whether it works in adolescents or not. Long-term antiretrovirals, we just started recruitment in the US and impact trial to 17. for rilpivirine combination in under age of 18, combination with long-term injectable implantable contraceptives, innovative ways to support adherence, mobile apps, school ART access, digital tools, gaming. We've done in my clinic as well, gaming where the opening of Vice pill box gives you points in your game, approach to ART as prevention for partners, when, teaching young people that being on treatment will increase the pleasure of the sexual life. This message really has not been yet delivered in resource-limited settings, but it gives them much more freedom in their sexual life as well, in addressing long-term toxicity and non-communicable diseases. And just to show you the results of breather study, this is one of the drugs where we're very careful, right, with a fibrance-based regimen. But this study was quite interesting. They officially allowed and agreed with young people that they could take 2 consecutive days each week off. A fibrance-based therapy, a low genetic barrier therapy, and the other ones were on continuous therapy. And I want you to see the results at 192 weeks. There was not much difference in the viral suppression between 2, which still tells us we really don't know well even the pharmacodynamics of the antiretroviral drugs in use, some unanswered questions. But it looks like being able to negotiate this kind of short cycle therapy plan really worked for the young people. Finally, challenges with retention and care in ART. Non-disclosure of HIV status is a huge problem. A lot of young people live, especially with perinatally acquired HIV, without knowing what they have. And a lot of young people struggle disclosing their status at home and in the environment. Loss to follow-up is huge. Transition and care, both from pediatric to adult settings, has been shown to significantly worsen outcome, but even horizontal transmission for adolescents is extremely damaging to the virological control. Suboptimal adherence, evaluation, and support. In majority of clinics, people really don't have time. The providers are overwhelmed. Young people require a lot of support. Mental health issues are totally still understudied and under-addressed. Substance abuse and lack of social protection. It's been shown poverty, abuse, violence, dropout of education is really detrimental to the health outcome of youth with HIV. And finally, we really need to train on our healthcare system in working with adolescents, which is still a very big gap across multiple countries and continents. I just wanted to show you that in this very rich resource country where I'm working as a clinician, with all the available means, this is our cascade on a national level in the US, where 56 youths, 13 to 24, who are diagnosed, and it comes down to only 27% of suppressed. So just to show you that resources don't always solve the issues, and you really need to have structural elements in place. What are the opportunities? Increasing resilience in self-motivation, self-care skills. There's multiple modalities have been tested. I listed some of them as an example. Peer support, and I will show you examples shortly of Zvandiri Katz model, camps, groups, media support, social media, support of disclosure in transition in care, comprehensive interventions for treatment failure, and increasing social protection, which is the most expensive of all. And just to give you some examples, I work with New Horizons Collaborative and APACC. We recently developed, if anybody is interested, please, it's on 3 languages, French, English, and Portuguese. Currently, it's management of treatment failure tool that allows you to quickly, at every level of healthcare provider, to identify virological failure and translate the viral load test results into action plan, specifically aimed for our children and adolescents, and also the tool that's less than 100 pages, but really supports the disclosure in multiple cases scenarios, including disclosure of adolescents to their sexual partners and including disclosure of adolescents to their families. And showing you the Zvandiri Katz model there, it's a very interesting model in Zimbabwe where they use young people who go in the community and they support young people. They support testing, they support treatment, and they have some fantastic results on the improved adherence and retention and care. They all are provided with a bicycle, and by now Minister of Health in the country has adopted it as a national model and is sponsoring it. And as I come to the end in the last couple of slides, I just wanted to show you very briefly that there are a lot of challenges and opportunities for research. Challenges are limited data. We really don't have much data on adolescents. Most of PEPFAR data is collected under 15 years, and then there are all together with adults, but we really need data on adolescents. Challenges of consent and assent for any studies because of the same limitations of age, retention, enrollment. Where do you recruit them? At pediatric sites, adult sites? We have a lot of unanswered questions. But there's some really good developments as well, including IAS and CIPHER. I'm very proud to say Dr. Khan has passed this to Linda Gale Becker, who has been a real champion for use. And recently, a global research agenda for adolescents has been published and is available on the website that can guide people around the globe of what kind of studies done, and other fantastic networks like ATN, ID, and FAAPs, following them for a long time. They've been really great work done by WHO about how the services need to be designed for adolescents, and those have been identified as accessible, acceptable, equitable, and appropriate and effective, and I won't go in details, but those are available online and you can easily find this tool. And finally, as I finish, I want to show you the quote from one of my patients in clinic. She's 18 years old, she has a fictitious name, and she says, growing up with HIV was honestly not that bad. Having a weak immune system at first seemed to be overwhelming, but as I got older and really understood, and this is really important, as I got older and really understood my medical situation, I began to just take care of this. This is just a part of who I am. And then a really encouraging paragraph that she puts for other young people not to let their dreams go and to keep going after their goals. And I just want to say we cannot do it without these people sitting at the table. So starting from study design to programmatic design, this kind of people and other people who struggle with treatment might not be suppressed. They need to be sitting together with us and helping us to make those decisions going forward. I want to thank adolescents and young people I've had a chance to work with and provide care for, several people who contributed some ideas and slides and data with me. I want to recognize Annette Son, who is now at a different session from Thailand, who's done an incredible contribution to overall adolescent agenda in this region and moving it forward. And thank you for your attention.